Thank you. Good morning. This has been a great symposium series, and it certainly motivated people without any obvious expertise in something like COVID to come up with something that might be a contribution. So what I'm going to show you is essentially the first results of a series of large phone surveys that we started in Bangladesh. The surveys were conducted by a team of 80 callers hired by Innovations for Poverty Action in the middle 2 weeks of May, and they've done a wonderful job preparing the questionnaires and managing this. And my collaborator on this project is Prabhat Barnwal, an economist at Michigan State University, with who is the lead of an NSF study, a randomized controlled trial related to arsenic mitigation, something we've been working on for some time. For perspective, this is yesterday's Johns Hopkins base for Bangladesh. A growing number of cases. If you look at the graph in the lower right, certainly no indication of a plateau or a decline in the reported cases. The first cases officially reported date from the beginning, the first week of March. The equivalent of a lockdown was declared in the last week of March. And since the end of Eid in Bangladesh, essentially what's been happening is that the lockdown has been relaxed and economic activity has started again. What motivated us to conduct this phone survey is essentially the sense that there are very few reliable data available to look at something that seems to be particularly robust, which is in the news reports we've seen, which is a measure of excess mortality for this year compared to last year. The phone survey was conducted in a set of 135 villages. You can see their locations ranging from 20 to about 100 kilometers northeast of the capital of Dhaka. And these were selected for the randomized control trial funded by NSF, essentially to test various forms of communicating well test results for arsenic. So they had nothing to do with COVID. We don't have any reason to believe that they would be unrepresentative, particularly unrepresentative of rural Bangladesh more generally. This study was started recently, the NSF study, but we have actually the School of Public Health, Mailman, and Dhaka University of Chicago. We've been running a large cohort study for 20 years in our Hazar. The villages that I'll be talking about, which are these blue symbols here, are to the northeast. So there's nothing about Hazar in this particular talk. And you can see that they are distributed on both banks of the third largest river in Bangladesh, which is the Meghna River. This was the pace of calling by this call center, essentially, this temporary call center. 1,800 calls per day attempted, so 20,000 attempts overall over two weeks, and all the information, of course, is recorded electronically on phones. So this is the first sort of result. The callers were able to reach 13,000 out of about 16,000 households after 2 attempts and trying 2 numbers. The reasons we have phone numbers for these families is that back in January, the last week of January, we actually had an in-person survey of all the households, including phone numbers, which was essentially the baseline for our randomized control trial. So it's somewhat serendipitous that we could build on that for these phone interviews after lockdown. So we were able to reach, so far, 81% of the households. This is important to keep in mind. We're going to try this week to push that to say 90% by calling neighbors and finding out what's happening and maybe new phone numbers. So the main result is that for each of these 135 villages, most of them have at least 1, if not several deaths. And that number, out of the population of a little bit more than 62,000, adds up to 479 deaths. That corresponds to a crude death rate of 7.7 per 1,000. That's higher than the most recently reported official crude rate of 5.5. There may be a number of reasons for that. For one thing, this is a rural population and doesn't include Dhaka, for instance. But there could be other reasons as well. So the big question, of course, is, well, how does this compare? How do the pre-COVID situation, how does the pre-COVID situations compare to what's happened since January? So, well, we can report that so far, 167 deaths were reported. You can see that some of these blue dots don't have the red circle corresponding to a death. So obviously a smaller number, about a third. If you prorate that number based on what Julian Day was sort of the middle day of that survey, you come up with 448 deaths over the year, assuming that this period was representative, and we'll get to that in a second. So that's, 448 versus 479. It doesn't look like a large difference. Certainly no doubling, as we've seen in some parts of Europe, and certainly in the mortality rate. And if anything, maybe slightly lower number. How does this look like when you break it down? First, there is a well-known seasonal pattern in the deaths in Bangladesh. May is a bit of an outlier here. So these are the numbers by month. And it may be related to the fact that people were telling us, well, that person died about a year ago. And so the enumerators enter that. So try to not focus on that too much. There is a well-established pattern whereby about twice as the rate of death is about twice as high during winter than it is during summer months in Bangladesh. And so you see something like that. If we look at the first 2 months of this year, you can see that there's no large difference for January and February. And then obviously May, it's just a partial survey, but the bar graphs start suggesting that if anything, there has been a decline in the total death rate for this particular population. What else can we say from our surveys? Obviously, we're asking quite a few questions. One is that there is the distribution of various diseases that were reported. It's all self-reported over the phone, but there doesn't seem to be any difference between this year and last year. Looking at the age distribution of the deaths, it doesn't seem to be a striking difference so far either. And finally, if you look at where people died or the proportion of female deaths, it doesn't look like there's any difference, large difference between last year and this year. The country, number of cases in the country continues to increase, and there's some discussion of at least reversing the free travel policies that have been reinstalled in the last few days. What else did we ask? Well, for a subset of these households, the 13,000, we have actually a longer interview. The first one is about 10 minutes, this one is 35 minutes, asking about risk perception, asking about whether someone in the household has been tested for COVID so far. Obviously, we want to do this on a repeated basis in the coming months. And essentially what this shows is that as of the survey, 46 of the household reported that at least one person had been tested for COVID-19. And you can see this surprised me to some extent. I thought maybe this would be mostly close to Dhaka, to the capital, because of transportation and contact. Instead, it looks like the yellow symbols are distributed pretty evenly across the entire set of villages. And out of those 46, only 2 so far reported that the test was positive. I'm not 100% sure what the tests are. I assume they're mostly antibody tests. There may be some PCR tests, some virus tests involved in this group as well. So this is essentially our results. The question, and maybe it might be great to get some feedback here on people who are experts in this. We have limited resources. We have heard some promising signals from DFID and from NSF that we might get the supplement to continue this. Nothing has been promised so far. Regardless, limited resources. Should we conduct smaller surveys more often? Should we conduct, wait until 3 months and do another large survey? We'd love some feedback. Thank you.
Thank you for an interesting presentation. And I wonder, is there a question about how accurate the mortality counts are in an area of the world where presumably access is limited to some of the areas that you're studying.
So you're talking about the registry, the civil registry, are deaths recorded properly? Certainly I went around the websites from the government of Bangladesh, and there is an official procedure. It looks like it is electronic today. I cannot tell you how accurate it is. That was, this question is one of the reasons why we wanted to conduct essentially our own mortality survey and keep tracking that in the coming months. And
one more question. In terms of how the testing is being done, I think you mentioned serology. I didn't get it. Is also RT-PCR, and do you know which modalities are being used?
No. So I know there were news reports about the fact that one of the antibody tests had been sort of invented in Bangladesh. I think it was actually imported from China and maybe modified. I also know from some of the people we have working in the field that some of their family members have been tested for the virus itself, but that was in Dhaka. So I don't know how widespread that is in the rural areas.
Michael Steckler, if you unmute, you can ask your question.
Lex, one thing in Bangladesh is that the incidence of COVID has certainly centered in Dhaka and Chittagong to some extent and spread out. So is perhaps part of what you're seeing is a lag in terms of cases and mortality in the more rural areas?
Yeah, I mean, it makes sense since Dhaka communicates with the rest of the world much more. If this came from the outside, I think you're right. It turns out that our area, certainly Arai Hazar, is part of the hotspot. But I think you're right, and maybe that's actually of interest that our villages spread over about 100 kilometers cover a span of sort of degree of communication with the capital. And maybe we started this, although we were worried that we'd be too late, maybe we started just in time to be able to report some changes. Obviously, we don't see massive changes, but they may still happen.
Margaret, did you have a question, or is that from the previous?
There we go. Okay, great. I was just looking at the chart that you showed of deaths and the comorbidities. It looked like diabetes was relatively low, and then I guess stroke was on the higher end. Can you explain the differences between the comorbidities in Bangladesh and what we're seeing in the U.S.?
No, I'm a mere geochemist, Margaret. I'm sorry. I'm reporting what our suggestion. Our main contact on the disease side was Steve Luby at Stanford, and he told us this would be a good set of questions to ask. I cannot comment on different types of diseases that prevail in Bangladesh. I'm sorry. Maybe someone else.